Here we are. Welcome to London, guys. Welcome to London.
It's a real pleasure to be here, and thank you for the invitation, and thank you also to the organizers of this wonderful symposium. My name is Edward Choke, and I work in Singapore, but I was trained in the UK, so it's a real pleasure to be back in the UK as always. My topic is recanalization strategy, antegrade, retrograde, and also bidirectional. There are no disclosures relevant to this presentation. So in terms of antegrade crossing of BTK chronic total occlusions, I've got two main aims. First is to try get it intraluminal. When I first trained in Leicester, I was trained with Armand Bollier, and he was one of the first to describe the subintimal methods. And to be honest, the subintimal methods of crossing has its own merits, but over time, for BTK especially, I found that if you provide meticulous techniques, then you try and achieve intraluminal, and from there you can achieve quite good long-term to medium-term patencies. The second is to try and avoid dissection. So I'm going to start with a relatively straightforward case. This is a patient with a CTO of the posterior tibial artery. You can see a nice proximal stump and a nice distal target. So with this kind of picture, this is my normal technique. I would use either a 4 French Bernstein support catheter at the top. If it's further distal, I'll use a smaller microcatheter, either a 2.6 French CXI or Rubicon. My workhorse wires are the V18 or the 014 Command ES. And from there, you can see, you can quite easily, most of the times, find the microchannel, and the wire will then sail through like this case. Always, for me, enter under direct vision, which means with overlay, and I would use the highest magnification possible so you can see your entry site and your target site, exit site. So this is the final result of this. So this is what you want to achieve with a nice brisk flow with as little dissection as possible.
Edward, can I just disturb you for a while? So we like to mention every single day that it's super fancy to keep intraluminal. So do you think that keeping intraluminal position in a 30 centimeters CTO is something feasible?
Not always.
Prof?
Not always.
What about you?
Excuse me.
Is it feasible just to be intraluminal, to keep your intraluminal position in a 30 centimeter CTO?
Not sure.
Okay, you need to convince them.
Can I make a comment?
Yep.
Can I just? I think I got exactly. I was thinking when we have a CTO, I'm not sure that we can use the terminology intraluminal. So I think there's no existing lumen at the moment. I think we probably need to just think about maybe either near-centric, we are going through the center of the, or what was the lumen in the past, or eccentric, something like that. The terminology seems a bit, I'm not sure that we can use the terminology intraluminal in a long CTOs. Or a short TOs, short occlusion is fine, or stenosis is okay, but otherwise, I think we probably need to use a different terminology. Because what we mean is we are near the old center, the existing center. That's what I thought.
Okay. Yeah, but that's good also, but we need to think also the CTOs, the long CTOs, many times, as we said, they're not all CTOs. You know, there's a little cap, maybe, and then all the rest, the guide wire moves super easily and super nicely. So essentially we need also to realize that sometimes what we see is not what we really is in the...
Yeah, I think I get your point. We tend to say that if the wire crosses straight, we are intraluminal, whilst it just cross loop, we are subintimal. And it's not the case in both sides. So you can just loop, but have a micronacal intraluminal. You can go straight, but subintimal.
Agree with all the points here. I think it's really, we can't tell exactly, I agree with you, exactly what happens in there. But as long as the wire sails down through like that, you're in a microchannel, you could potentially say that this is how I would classify as I'm in the intraluminal. If the wire knuckles, then I'm in the subintimal space. This is my, how I look at it. So this is a common scenario. A lot of the CTOs will have collaterals coming off it, and very frequently your wire will then sail into the collateral and refuse to engage. So the first poll is, if this were to happen, and this is a very common scenario, what to do if your workhorse wire, either 014 or 018, bounces off the CTO and you can't get it to engage. And we listened to a fantastic talk by Daniel earlier on. So the first option, in this case, would you then escalate to a CTO wire? In this case, this is a peroneal artery.
Raise your flag if we escalate to the CTO wire.
Or use another wire with different properties. Yeah, I see a few hands here.
Very few hands. Balloon catheter and wire?
Yeah, so this is from the amazing, from your paper. So there's a lot of techniques to try and achieve antegrade crossing. So I really encourage you guys to get hold of the paper. So balloon catheter and wire.
Balloon catheter and wire, many people? So you would inflate the balloon and would try to get more, okay?
Telescope technique. Put a Bernstein and then use the microcatheter to then just jam into the proximal cap. See, quite a few. And lastly, power crossing balloon at the side of the wire. I've never used that before, but it's described in your paper. Anyone will use that? It's not so many. Okay, so I can see maybe 1, 2, and 3.
And also I think there's even a fifth, like you can get the retrograde access. If you're unable to get, because the collaterals, you know, the retrograde access, if there's a good distal, and probably we will go through this later, but it could be a good option. Because I mean, many times, especially in SFA pop, when you have these kind of big genicular arteries, which are occluding the posterior tibial, there's no way. You can try whatever you want. The passage is so smooth in these big collaterals that there's no other thing than to either to take a guide wire and try to penetrate and go God knows where, or either to get retrograde access where you can avoid the collaterals. That's another option also.
So for me, it's the telescope technique, which is my personal preferred technique. So with this telescope technique, I first actually will try without using the Bernstein catheter first. So it's a very simple step. You've already got your microcatheter in there. So really push the 2.6 French CXI catheter into the CTO cap for support. And I find that a lot of times, you can see it's very subtle there. Once you push it into the cap quite hard, and you push a wire in, either 014 or your workhorse V18, usually you can engage the cap and you will go down like that. So this is my preferred technique. If this were to fail and I were to need more support, then I'll push in a 4 French Bernstein catheter for more support using the telescope technique. So this is another case of a complex BTK case with the only runoff being the peroneal artery. You can see a nice reconstruction of the distal anterior tibial artery, and that's the target artery down to the foot. And in this case, I put in the 4 French Bernstein catheter. Another, really common scenario, like I explained earlier on, you see how it bounces off the proximal cap and goes into the CTO. So I use the telescope technique again. First of all, the 2.6 French CXI catheter into the CTO for support. And I use a V18 wire in this case. And what happened in this case is this bit here. You can see knuckling already. So I know at this stage, if I were to push anymore, I'll probably cross the lesion, but I will be in the subintimal space, and the result will not be as nice. There'll be a lot of dissection. So that comes to the next poll question. If this were to happen in your case, and it's a very common scenario, I'm sure, you don't always go intraluminally. What do you do in this case if you're unable to cross antegrade intraluminally? Do you persevere with antegrade using the knuckle technique and complete it with subintimal crossing? Or do you go retrograde? Red for retrograde, green for persevere with antegrade. So I think we see...
Don't be shy. I mean, if you want to raise...
There's no right or wrong answer, because I have to say that earlier in my career, I did one of these, but now I've got there's no level 1 evidence. I prefer the other option. So looks like it's more red. What do you think, Lorenzo?
Yeah, more red. I think I also would go retrograde because it permits you to, it's a long occlusion. So if you want to go, I think, subintimal for a short tract, you can even put a stand, you can achieve a better luminal gain. If you have a long CTO and a decent distal target, I'm a big fan of retrograde. So yes, personally, I agree with you. Jean-Baptiste?
It is possible also when you make retrograde puncture that you navigate inside the patent vessel and then you go subintimal also from the retrograde. It's not sure that...
So I completely agree. So that's why we look at the what it looks like first from the earlier on, what distal target looks like and how calcified it is. If I think even if I go retrograde, I'm going to achieve the same subintimal crossing, then I will persevere with Antegrade, absolutely.
As we said before in the session with Shockwave, remember that very calcific lesion? We said it doesn't matter if you go antegrade or retrograde, you will always go subintimal. The retrograde access still gives you the possibility to play with the two wires. So essentially, it won't destroy potentially, because I think the worst you can do, to go down with a loop and dissect the whole dorsalis pedis till the first metatarsal. That's something we should be avoided. So you can go with the micro, I mean, in my experience, with the micro knuckle as soon as you find that the distal target you are just dissecting. This is where the bypass then won't be possible because you dissected the whole vessel, and this is where you really risk to destroy the foot and the foot arch.
So I think it's really important if you're dealing with CLTI, really be comfortable with retrograde punctures, and this is how I do my retrograde punctures, and this is a very common technique. I'm sure a lot of people also use this technique. So it's a shiftless technique. I use a 21 gauge green needle, which is an echogenic tip. My retrograde wire, and I listened with interest to Daniel's talk earlier on, where he initially started off with V18. I still use the V18, but I might try the 018 Halbert to see if it makes any difference in terms of the trackability. And after getting the 018 wire in, the first thing I use is the 2.6 French CXI catheter. That's very important. Get it in there as soon as possible. And once you're in there, then you do a crossing, and this is the end result of this. You want to achieve a nice kind of intraluminal crossing through a retrograde with as little dissection as possible to try and get the best long-term patency in these patients as much as possible. So in terms of the punctures, there are many arteries down below that you can puncture. The ATA, first of all, for ATA, I think the best technique, in my personal opinion, is to use the ultrasound guided. You can see normally there's a vena comitatus next to it. There's a calcified portion of the anterior tibial artery. I generally use a hockey stick, and then I puncture in a transverse fashion into the middle of it.
Here we are, transverse fashion.
Yeah.
Okay, for the ones who puncture dorsalis pedis, how many, so it's a green flag for transverse and instead red flag for longitudinal. Okay.
Half.
Oh. I'm a big fan also of this.
Let me ask Pierre, why do you use the longitudinal?
Yes, with longitudinal, sometimes you seems you are inside and you are on the side, you are on the wall, and with the transverse you are quite sure to be just in the middle of the. Of course, you have to move the probe millimeters by millimeters to be sure, but I find that's quite more easy.
Okay, let's go on.
I think there's a hand raised as well.
But in the other way, with the PT, I'm sorry, I don't want to cover something you're about to say. Are you about to talk about PT?
Yeah, as well, yes.
Okay, fine.
So I'm going to go through. So once you've entered it, then you see this nice flashback and you know you're in business. It's a bright red. Sometimes you can get into the vein, and that's the vein color, so you know you're in a vein. And from there, you advance the V18.
Sorry, I'm interrupting you again. Can you show the video again?
Yep.
Because this is so important. If you don't have this bleeding, back bleeding, forget about being inside the artery, okay? So I don't want to see anyone puncturing and then try to advance the wire because it's okay? That's the worst you can do. So you need, even in this extremely small, diseased, unfed vessel, there's always a back bleeding like this. If you don't have this, forget about advancing a wire. Do we all agree? Green flag if you agree.
That's a very good point. I have to say I've done it before when there's no back bleed.
Yeah, but then you know from the beginning that the vessel is occluded.
Yes.
Okay, because if if you know that the vessel is patent, you need to have a back bleed.
Correct. Okay, so we've been through this before. I use the shiftless technique and I use the CXI support catheter to push it up. For PTA puncture, for me, if it's calcified, I will use a fluoroscopic guidance, and it just lends itself to a very nice visualization, and it's in real time, and you got less to control. So first of all, I place it in the lateral position. I puncture it along the line of the vessel, going deep, and at some point you will pass it. And once you've passed it, you feel it because it's so calcified. And then you change the projection to a 90 degree, and then you can see that if you're inside, then you push your wire through. If you're not inside, you just pull the needle back until you're inside the artery. If it's not calcified, then I will use ultrasound guidance for PTA. You were going to mention something about PTA retrograde punctures, was there?
No, it's fantastic. I completely agree. Just for me, because it's so mobile, the PT, this is when I do puncture longitudinally to stitch the wire and do true Seldinger, go through and through and then pull back and then visualize the guide wire under ultrasound up the artery. And that's the main difference for me between a DP puncture and a PT puncture.
Also because the anatomy helps you. Because you put the probe nicely, but on the DP, it's difficult to put the probe, it slips.
I see, August, you were about to say something. You published a great technique on how to keep it from being
that's
a very mobile, calcified artery. Yes.
It's really, really difficult to puncture because whenever you try to punch it, they just refuse to be punctured. And probably Marta has the answer.
Well, you can use 2 needles using the body needle technique published by our group. Even you can use 3 needles in a chopstick manner in order to keep the artery without movement. So you use the needle and you puncture with another one, with the needle technique. This is really useful.
Great technique. So I encourage you guys, if you haven't read the paper, go and get the paper. Fantastic technique. For peroneal artery, almost always I use the overlay fluoroscopic guidance. So puncture in line with the peroneal artery, and you know that once you're in this case, I normally go past it. And once I've gone past it, you can see in the last diagram there, I will then change the projection to at least 90 degrees difference, and I will pull it back until I'm inside the peroneal artery, and from there you can then track your retrograde wire through. LPA or MPA puncture, I also use the overlay fluoroscopic technique. I think using the ultrasound is also possible, but my ultrasound skills are not good enough, so I tend to use the overlay technique. And this is a lateral projection of the foot. My tip for puncturing lateral plantar artery is always, if possible, puncture more proximally. If you puncture in distal, once it makes that band, this is the band as the artery goes towards the other side of the foot. And in this angle, if you can puncture it, but then when you project it another angle, it will be in a very, very 90-degree angle. It'll be too acute for you to pass the wire in. So that's just my only tip for puncturing LPA. Popliteal or SFA, if it's calcified, again, I'll use fluoroscopic guidance. In this case, I was working on the right leg. You do a lateral projection to do the puncture for the right leg. In this case, I did a LAO projection. If it's for the left leg, I'll use an RAO projection. And if it's not calcified, then the other technique is to use the overlay technique, as in this case as well. Yes?
Can I just ask a quick question on the panel? We're seeing a lot of angio images with fingers in the screen, and I know that the way I was trained, it was this forbidden technique. But I cannot deny watching you do it. Yeah. It looks very easy. So I don't mean a show of hands or flags, but is this something other people are doing? Are people as perturbed by seeing fingers in there? Is it an issue? Because Edward's technique makes this look a hell of a lot easier than some of the struggles that I have. So I'm interested to know, has anyone got any experience, anyone got any thoughts, any comments about it's fingers, isn't it, in X-ray? Is this an issue for us? Is it not an issue for us? Because you're making it look really easy.
It is an issue. Obviously,
there is a comment on this.
Hi.
Please.
Barry from Leicester. Hi. It is a real issue for us, especially I think it's in UK, maybe process everywhere, because we will be putting a lot of reviews for these kind of images if it's been shown in the MDT. If we have our fingers like that, now we started to use this lead covered gloves. So leaded gloves, that may be useful. But many times when we use these kind of things with your fingers in there,
I get shouted at. My radiographer shouts at me.
Will be reported straight away.
Yeah, I'd like a question, Edward, in your left. Do you use a ring dosimeter regularly?
I use the one that I put in the outside.
Okay, and that what's the doses that you get?
So far, it's I I do not know the exact doses, but we have to submit it every few months.
I use a ring dosimeter, and I do a lot of also this kind of procedure with hands. And although I shield myself a lot, I normally get over 30 to 40 millisieverts per month. And I remember that the maximum doses for fingers and for outside of your lead apron is about 500. So 500, yeah. So we're really under to those, but no one really knows if that has any problem.
Thank you very much.
There
Thank
are
you.
two solutions. The one is with the gloves, and there is also from Spectranetics, previous Spectranetics, let's say an extension to the needle that you can puncture from far away. So, and you can.
Yeah, but guys, we are talking about, like, I personally think, like, if you put the lead gloves, you will not feel anything more. You don't even know if the needle is in your hands. On a telescopic, I mean, this is something that you don't do that every day, 3 times a day. You do that sometimes, and if your finger's going there, I think also as a radiologist, it shouldn't be an issue. So I don't want to hear, I don't like to hear people say, I don't do that because I need to put my fingers under the screen. I mean, come on. It's like the time that you put your fingers there, and you can even work a bit better with your radiographer to get a better field of view, more restricted.
Smaller.
It's small. So this is a false issue, and I would like, it's nice to have this kind of comments because it's.
I know it's super fancy just to say that we perform all of our retrograde punches ultrasound guided, but I think there are anatomical restrictions. Yeah, you can puncture at the level of zone 1, at the level of the ankle, but not at least in my experience, in the middle of the leg, or if we are talking about the forefoot. So what are the anatomical limits of an ultrasound-guided access?
Edward, however, I have to ask you something, because I have seen that Lorenzo has also shown in a previous presentation, not today, in another congress. Why to puncture P3? Why not to go further down and puncture, for example, a tibial artery? Why to do this kind of retrograde puncture?
You get more support. So frequently for extremely calcified SFA popliteal, if I find that with the tibial, by the time I push up there, I can't get the wires to meet. Yeah.
Okay, sorry about that. Puncturing the P3 is not so frequent, and a lot of people is not aware which is the technique itself. You have shown it like more or less. How many of you perform a P3 approach from the anterolateral aspect?
With the patient supine. With the patient supine.
And not from the medial aspect. It's like, do you want to know how to perform that? Just yell, yes! Tell them.
The important thing is the projection. So that's why I was making a point of it, that the projection is important. For the right leg, use LAO. For the left leg, use RAO. And that's the only way you're going to get room. Position the wire a little, the leg a little bit bent like that. And from there, you can get a nice view and a nice puncture into the P3 popliteal. So in this case, I was working on the right leg. The projection is LAO, and there's plenty of room to put a needle in there. Again, I use a 21 gauge needle. Everything else is the same, just the projection is important.
Can I just ask questions? A very nice talk, and I like the discussion. So can I take you back to the tibia recanalization? I'm here.
Yeah, hi.
The tibia recanalization, because one of the tricks is how far distal you go to do your retrograde puncture from the CTO. So if you have the CTO extending to the lower third of the tibial, for example, I've seen a picture where you puncture the DP in the foot, which probably will be your target vessel for a bypass. But on the other hand, you want to have a space long enough to manipulate your wire for retrograde. How do you get the balance right, or do you give up completely?
It's a balance. So two factors. Choose a nice spot, that's first of all. And secondly, as Lorenzo said, give yourself enough maneuverability and support. That's important as well.
Very good, yeah.
So I just want to enter some pitfalls into snaring portion of retrograde. So for example, in this case, this is a occlusion of the anterior tibial artery, a small stump. The problem is, if you were to push your wire up into the popliteal and you try and snare there, and this is a potential pitfall. Your wire may be in the subintimal space in the dissection, and I could potentially put my Bernstein catheter in there and snare there. But if you do that, in this case, you will lose inflows to all the other tibials. So really be careful about doing this. For me, my rendezvous in the tibials is to always rendezvous within the tibials itself and not in the popliteal to try and avoid this potential pitfall. So in this case, for example, I would position my CXI catheter from the bottom, do a run to make sure I'm back in the luminal space, and from there, and this is my rendezvous spot and not in the popliteal artery. This is my personal preference, but if you were to choose to do in the popliteal, just be careful that you're not going to lose the inflow to the rest of the traffication.
Here we are.
Yes, and the other pitfall is, as we mentioned earlier on, beware of shearing off of the wire. This is a 21 gauge, and this is a V18. If you feel it getting caught, forget it. Pull the whole thing out, wire with the needle, and don't leave your wire in there.
Now, here it was my nurse are always worried, you leave a piece of a guide wire in the UK, it's like it's almost killing a patient, like you don't care about the recanalization, but you leave a piece of a guide wire, then you need to highlight, it's super bad. Yeah, so yeah.
It's super bad.
But you see, it happens also in other countries, guys. It doesn't happen only to me. Yeah.
Okay, so what you do is there's a flush occlusion of the tibial artery. This is the you don't know where you're at, so you need to go retrograde. This is a peroneal artery, got a nice distal target there. And the only thing I would say in this is that in this kind of situation, again, this is the discussion later on as to whether you rendezvous there or you rendezvous here. My preference, for the reasons explained earlier on, is to rendezvous in the red area, push the Bernstein catheter down into the flush occlusion. Usually, the retrograde wire will tell you where to go, and from there, you should be able to rendezvous safely at that point. And from there, hopefully, get a nice non-dissected portion, preserving the traffication to your peroneal in this instance, and also the posterior tibial artery.
Is Alessio Spinelli here? Alessio, are you here? No. Because he calls it the sheep technique, which I love it. The sheep. Yeah, you go with the little retrograde access as a dog, and then you go back, and the sheep wire comes back from the top. So I think it's a good way to describe this great thing. Conrad.
I think it's a really valid point about not losing when you rendezvous perineal or maybe the whole TPT. And something I've started doing is crossing with the IVUS catheter and actually seeing where the sleeping or the occluded AT is, and mark that on my roadmap so I don't allow my dissection flap to go past there. And then using the IVUS catheter as my crossing catheter is something I've started to use. I don't know if other people have that experience.
And the IVUS is from the Antegrade or?
Yeah, normally from Antegrade. Yeah. But let's say I'm down the TPT and I want to know where that perineal is.
Yeah.
Rather than just blindly stabbing with an angle catheter, actually marking it and being didactic and saying, this is where I'm going to point my angle nav across.
Yeah. The Japanese have also, they describe this technique when they use the IVUS to cross CTOs as well. So with the IVUS, we're learning a lot of new things with the IVUS. So I completely agree there, thanks. Okay, next thing is, you're spending a lot of time crossing, puncturing and everything. You really want to minimize your time to find the exact rendezvous spot. And for me, this is how I teach my fellows. I ask them to look for the X spot. So the principle is this: if the antegrade and the retrograde wires remain crossing to each other in all projections, then they must be in the same plane at that crossing point. So I'll demonstrate with this case where a severely calcified SFA. So you can see here, the wire will go into quite a lot of places, but there's one spot there in which it crosses, and when I move the plane projection from lateral to lateral, there's one spot there that remains fixed. That spot there must be the area where the wires are in contact with each other. And it's a very, very precise thing, and it's very, very reproducible. So once I've done it, and I'm sure that that's the crossing point, I will push the Burr catheter down to that crossing point there. It's the first thing, position it there quite accurately. And then from the bottom, the CX is supported with a CXI catheter, pull it down into that point, like so, and then from there you can see it will go into it, no problems. So when I push it from it will go into it. So this one is just really a method for us to try and reduce the time to, otherwise you'll be like checking, it's just a trial and error method. So this is one of the. It also can be used for BTK lesions as well. It's a little bit more subtle, but you can see some parts the wires are diverging, some parts the wires are crossing each other, but in where it crosses, that's the point where that you will always go into it. So retrograde via pedal plantar loop, that's a very important approach as well. It has to be in the armamentarium of all. For us, when we approach it from the dorsalis pedis, we always try and do it in the AP craniocaudal projection. We use a 2.6 French CXI catheter, 014 command. And there are two techniques. This is a knuckle technique, but just be really careful not to dissect. So there's always a first curve to cross on the AP craniocaudal. And in this instance, I use a knuckle technique, careful knuckle technique. For the second curve, I will push my CXI catheter past the first curve already. And from there, I will, usually my wires I've already pre-made into a little curve. And from there, you should be able to negotiate yourself around the plantar arch. In my experience, for the PTA, the lateral projection is sufficient to cross for the PTA. And do not forget, there's also another way to do the pedal plantar loop through the medial plantar artery. And August has got a really nice picture in your LinkedIn profile, so I would really, it looks like when you go around the middle plantar loop, it looks like a heart shape. It's very, very romantic. So this in a craniocaudal projection. So don't forget, if you really need to, use the middle plantar artery approach. Yeah.
Okay, let me just underline a really important fact, because we have seen that this flat panel moving all around. We usually see people just doing all of the BTK, BTA stuff with a really static position, and it's really important just to keep on moving, just to keep a clear idea where is your wire, where you're aiming to go. So just keep on moving your C-arm or your flat panel.
Yeah. Patrick, can I ask you a quick question just here on the panel? How important is IVUS in your below-knee practice? Is it something that you use routinely, selectively? Would you just
selectively? Selectively. So I don't use IVUS in all. I would use it for a few indications. Number one, if I really want to know exactly what size balloon I use. So if I think I'm going to use a bigger balloon, sometimes even 4 millimeters to below the ankle, I will use IVUS first to make sure. Secondly, if I were to use an atherectomy device, I want to make sure I'm in the subintimal plane. Not in the subintimal plane.
The importance of not leaving dissection behind. And of course, we know that angiography is one way, but often what we see on IVUS isn't what we're seeing on angiography. And I just wondered if it was something you might use routinely. But no, just selectively.
Yeah, mainly for those two reasons at the moment. But we were finding more and more indications for using IVUS. Yeah. So this leading up to the last poll. So this is a lady with a heel ulcer, and I had attempted to cross into that nice posterior collateral branch to the LPA peroneal, but this failed. So in this kind of instance, we've got the options of three options really. Retrograde puncture here to try and get into the peroneal artery, pedal plantar loop approach to go around, or change your wire, antegrade down the peroneal artery. So red flag for pedal plantar loop approach, yellow for retrograde puncture, green for CTO wire, antegrade down the peroneal. Yeah, I think most people are red, so this is what I did. So this is
you see, just as August said, he changed completely the projection. So if you want to navigate the foot arch properly, you go in anteroposterior view. Because it's a disease foot arch, it's not a great foot arch. And if you don't go in anteroposterior, then you will lose time going to the metatarsal arteries, you will end up in dissecting it. And if you dissect, then you will cry, I think.
Okay, and this is the end result. And this is the heel ulcer, I think it was 2 months afterwards. So really, on to the last case now. I realize my time is short. Sometimes you get cases like this where you've got nothing. It stops in the TP trunk. You've got no idea which arteries are which. So the pedal plantar loop approach here is absolutely essential in this kind of instance. So first, a retrograde puncture into the posterior tibial artery, and that will allow me access to then get myself, and that will give me access through the posterior tibial artery to complete the pedal plantar loop approach artery into the anterior tibial artery. That will save me another puncture into the dorsalis pedis. And from there, you can then go all the way back up to the top. And because I normally use a 6 French sheath, I'm then able to put in another Bernstein catheter from the top, and using that, what technique was it that you're saying you're pushing?
The sheep technique.
The sheep technique. Then you can then get first of all, you know where the anterior tibial artery is. Second, with the kissing wire technique, you should be able to pass your wire into the anterior tibial artery, which you could not have visualized otherwise at all. So the final bit here is where the wire will enter into the anterior tibial artery through the bidirectional approach. And from there, from nothing, just the peroneal artery, you can reconstruct the entire traffication, get a nice posterior and anterior tibial artery flow, and get reconstruct the plantar arch in this instance. I think, sorry, this is the last case. Have I got time for this? Okay. So again, this was one of my great saves, and this was only about 3 months ago. This is really using the, one of my fellows used the pedal plantar approach in order to save this chap's foot. This is acute limb ischemia. You can see the sudden cut off there, nothing to the foot at all. The foot is in a bad shape. This is a young gentleman in his 50s, in serious trouble. In fact, when I looked at this was fixed mottling, and I wasn't sure if he could save his leg, but he wanted a chance at it, so we went to it. Managed to cross, but didn't do the pedal plantar loop approach on the first setting, antegrade to the tibial arteries, overnight catheter-directed thrombolysis, urokinase 80,000 units per hour. But still, this is the next day. Poor BTA flows the next day is obviously all silted up from there. In this instance, really, we chose to go around it. And by going around it, the advantage is that then we were able to put our cracked McNamara infusion catheter in the plantar arch itself, gave him a second overnight catheter-directed thrombolysis, and this is the end result the next day. With a reasonable flow around through the arch with a palpable dorsalis pedis pulse, and this was him about 1 month later with a forefoot, and you can see the fixed mottling is all healed. So to summarize, as CLTI, if you want to deal with CLTI, then I think personally you need to know these techniques really well. Antegrade, first of all, that's bread and butter. Intraluminal and subintimal. Retrograde, need to know how to puncture these arteries, in my opinion. And the pedal plantar loop approach. For me, I keep my inventory to a minimum. I use some other CTO wires, but for me, the workhorse wires are V18 Command ES with workhorse catheters, Bernstein 4 French, and a CXI 2.6 French microcatheter.
Thank you so much, Edward.
Amazing.
So,
big round of applause, Mr. Edward Chu.
So, Edward, now I'm sorry, but probably I'm not the most intelligent in the room, but I'm completely confused now, because on the first presentations we had Daniel. Please take the microphone, Daniel. We had Daniel that invested a lot on wires technology, and he said you have to change wires and you have to do that and to try to learn how do you call it, the nice chart. And you are showing us that you're trying with your wire, it doesn't work, you're going retrograde, everything is fine. And all this technology and theory behind wires for a retrograde approach actually doesn't play any role, because you're using only one workhorse wire, a V18, and you're taking your CXI and you're going through everything. So now, I am, let's say, a guy that wants to start doing CTO lesions. What should I do? Should I focus on wires? Should I focus on the retrograde approach? Should I focus on taking better support catheters? So I want a comment from your side and a comment from Daniel to close these nice two talks.
Okay, my personal opinion is you know your wires really well. I think that's the most important, and know your support catheters really well. You can choose any wire you want as long as you know it really well. For me, I know the V18 and the Command ES the best, and I know the catheters the best. In my practice, 95% can be done with this technique, but I still keep CTO wires and the rest of his wires in my cupboard as well for the remaining 5% of the cases. Yes.
Can I make a comment? Thank you, Edward. That's a very good talk. I think I completely understand your point as well, because I think the retrograde approach is quite useful. From my point of view, the take-home message from this talk is actually antegrade access is commonly used, everyone will be knowing, but retrograde access will be not as easy as what they have shown, because it's not, they are expert, right? They probably have done, and it's, whenever I tried, I'm not as expert as them, so we will struggle. So therefore, I think to use which wire, so I tend to use antegrade using different wires more than the retrograde access, simply because, for example, plantar retrograde access will be a bit challenging for me, and also maybe I'm not very technically skillful. So I think whatever everyone's cup of tea. Some people are quite capable of doing retrograde access, so they might want to change to retrograde access quicker than the others. So I think at the end of the day, what we need to know, what is my skills, what is our unit skills, what sort of bias we have, all the bias knowledge we should know, and try to find a way to recanalize one way. But I'm really congratulate you for the last case. In most centers, they would have taken the leg off because there are fixed mottling and they wouldn't have, attempt to salvage. Placing a thrombolysis catheter into the period large will be very, I haven't done it before, so I'm sure that's a good learning point. But I think most centers, I agree, I think they would have taken the leg off rather than trying to salvage. I can actually ask for a vote. Who would have tried thrombolysis on that fixed mottle patients? Anyone? So say someone who would have gone for thrombolysis red and the amputation green.
Amputation green, thrombolysis red.
I would have gone for amputation straight away, most likely. But I think it's very good. I mean, it's nice to know these things can be done. Thank you. Well done. Thank you.
Thank you.
Still want me to comment? Or?
Yes, please.
Okay. Yes. So I might have given the impression that my escalation would be, if it doesn't work, then use a CTO. That's not the case. It's dependent. Each case should be is a different case. So if I'm not able to cross Antegrade with my workhorse guide wire, I have a good distal target to puncture, I will go retrograde. So it's not about this is always my algorithm, my escalation algorithm. It's different.
But in the retrograde approach, you do not escalate the wires. Or
of course
you can, but you're not. You're not describing
so
this.
what
That's
if,
the point.
like just the comment before, you go from retrograde and then you're also in a subintimal plane. I use CTO wires to get re-entry. So I penetrate the intimal flaps. So
this is an important message for everybody. That doesn't mean that you are going retrograde. One wire fits everything.
No, for sure not. No. I wish it was true, but no. So each case, each artery requires almost a different approach. And I think the most important message is that you know your wires, you know your favorite catheters, and you know what makes you successful.
Completely
and
agree.
That's the most important. And for me, that's a certain combination of a support catheter and a wire. But for different physicians, will be different tools. But you should know what's possible.
Let's close with two little remarks.
Yeah.
Giambattista and then Martin Malina.
In order to give an answer to the confusion of Theo about the algorithm, in our institution we have the 10 minutes rule. We try 10 minutes from the Antegrade and we go with the wire escalation. After 10 minutes we change and we go retrograde. I think this is for the educational point of view, for the young people. If you think that it is possible to make retrograde puncture, you try 10 minutes from the Antegrade and then change and go retrograde.
Okay, and all the cases are finished in 45 minutes then, yeah? Martin, what do you want to say?
I hear a lot about various wires, but I also think it's important to know how to handle the wire, no matter which one it is, and particularly rotating the wire. I find very often that people go up and down, trying to push, but they forget about gently reshaping the tip and rotating the wire rapidly, like a dentist's drill almost.
Okay.
Because I usually tell them that the wire is smarter than us. It's the wire that finds its way. It's not us guiding it through.
Yeah, forget about the violin player. Just like, this is a nonsense.
Exactly. So, I mean, it's a combination between the operator and the guide wire. Thank you so much to Edward Choke. It was super interesting talk.